Welcome, everyone. Thank you for joining us today. My name is Kerry Grady Vincent, and I am the Senior Manager of Clinical and Educational Programs at Osteoporosis Canada. I will be your moderator for today's webinar, What to Expect After a Hip Fracture. Before we begin, Osteoporosis Canada acknowledges the land that our offices, located in Toronto, are on is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. At Osteoporosis Canada, we educate Canadians about bone health, including healthcare professionals and their clients. We are the only national organization serving people who have or are at risk for osteoporosis. We are really excited about today's presentation, which will provide information about hip fractures. Breaking your hip is not something you can plan for, but should you or a loved one be in a position where you need care, it's important that you have the essential information to help you navigate healthcare needs. Today's presentation will discuss why and how a hip fracture occurs, the need for surgery, what to expect post-surgery, how to protect from further fractures, as well as a lived experience story. It is not intended as individualized health advice, and if you have questions about osteoporosis, please consult with your healthcare provider. If you have questions during the webinar, please remember to click the question and answer button on your screen to submit your questions, and we will try to get to as many as we can, time permitting. Before we begin, make sure you have your speakers turned up fully so that you can hear the presentation clearly. It is now my pleasure to introduce our speakers, Dr. Jenny Thain and Sue Lakhani. Sue is a retired software developer. Together with her husband, they ran a software company specializing in internet restriction software. When Sue retired, she and her husband embraced cycling every single bike trail in Ottawa during the pandemic. Her passions include being outdoors, hiking, biking, camping, and now glamping. She is also committed to volunteering and giving back. In 2008, Sue was diagnosed with osteoporosis, and at age 62, she unexpectedly suffered a broken hip. Our other speaker, Dr. Jenny Thain, is a geriatrician and associate professor within the Division of Geriatric Medicine at Western University. Her areas of clinical interest include osteoporosis and bone health, with a particular interest in orthogeriatric hip fracture care. She is a member of our Scientific Advisory Council, chair of the Canadian Geriatric Society Osteoporosis and Bone Health Special Interest Group, and a member of the Fragility Fracture Network Scientific Committee, North American Steering Committee, and Board of Directors. Dr. Thain is a co-author on the Canadian position paper addressing post-hip fracture orthogeriatric care. She's also active in medical education and is the program director of the Western Geriatric Medicine Residency Program and Orthogeriatric Fellowship. So without further ado, please join me in welcoming Sue and Jenny. Sue, do you want to take it away?
Thank you, Kerry. Hi, everybody. About a year and a half ago, I had the unfortunate experience of falling in a gym, changing room, and breaking my hip. And it was very ironic that I should break my hip in a gym because I considered the gym my refuge, a place that I loved going to after spending hours hunched up in front of a computer. So physical activity has always been one of my passions, especially being in the outdoors. So this rather freak accident filled me with a lot of anxiety, especially when I was laying in the operating room getting ready for my surgery. The best thing that happened to me at the hospital was that after 12 hours of the surgery, a couple of physiotherapists came to my room and just whisked me out of the bed and forced me to start walking with a walker. And I thought, oh, this is impossible. I couldn't do this. But to my surprise, I took baby steps right up to the end of the room. And that was the beginning of my determination that I was going to get better with this accident. And I must say that exhilaration even was far better than nailing a high impact cardio. So from my experience, I felt that there were three factors that really helped me with my recovery. One was definitely physiotherapy, just following it to the T, good nutrition. And in my case, I also felt that solo activities like meditation really, really helped me. The physiotherapist was excellent. We set goals because I'm a goal setter. So we set goals for on a weekly basis. And every target that I managed to reach gave me a lot of confidence, especially when I could see improvements in my mobility. With nutrition, I've always consumed a lot of calcium, but I was told that I didn't have enough protein. So I really upped the protein. And in terms of quiet activities, I love meditation. That really helped me to center myself, reading. And once I got stronger and the weather wasn't bad outside, it was the fall season, I managed to get out into a trail near a house and walk slowly. And that I found very, very healing. Hence the term bathing with the trees really made sense to me at that time. 6 months later, we had a trip scheduled for Bali. And so we went and we climbed Mount Batu starting at 3 o'clock in the morning to reach the peak in order to capture the sunrise. And when I made it to the peak, that was the crowning achievement for me of my journey through this fracture. It really gave me a lot of confidence that I will be able to do all the activities that I was doing prior to my accident. So basically, the only thing I felt during my journey, I felt really lonely. Emotion, it's a different kind of lonely. I mean, I was surrounded by a very loving husband and family and friends. But when I came back from the hospital, I felt I needed to talk to people who had gone through the same thing. And I felt that there was these discussion forums that were missing. So my goal is that I'd really like to be that support person for people who are going through this. I'd love to help them understand what to expect and how to motivate themselves. And also, I would love to promote more knowledge about the nutrition and strengthening exercises, especially when you have osteoporosis. But my thank you goes to the medical team. I had amazing, amazing assistance during my time in the hospital. It went beyond my expectations. So thank you to the entire team for making me better. And thank you to Osteoporosis. I actually joined a support group where I got a lot of information as well, from medication to more nutrition, exercises, and I still participate in that group. I get invaluable information. Thank you. Thank you, Kerry.
Thank you, Sue. That was wonderful. Now we will turn to Jenny. Dr. Thain.
Great. Thank you so much. And thank you, Sue, for sharing your story. And I'll probably come back to your story later on, but I think you really have encapsulated all of the main things that I wanted to talk about today with regards to, nutrition and exercise and things that you can do to help yourself as we get over a hip fracture. So thank you very much for having me here today. As I was reflecting on all the things that I've gone through to try and train in this area, I was thinking it's been nearly 20 years to the day that the first time as a medical resident I stepped on my first foot into an orthopedic unit to look after a patient with hip fracture. So I'm hoping that I'll be able to take some of that kind of knowledge and pearls and tips and be able to share it with you today. To help you learn more about this condition. So these are my disclosures. So this is a general outline of what I'll be talking about today. We only have about 30 to 40 minutes, so it's not going to be completely comprehensive, but I'll try to give you as much information I can about hip fracture, about your care team, what to expect before and after surgery, and things that can be done to try to optimize care in the post-operative phase. And very importantly as well, what are things that we can do to try and prevent future fractures from happening? Because if you or a loved one have gone through the experience of having a hip fracture, it's certainly something that you don't want to do again. So I thought I would start off just with some fast facts about hip fracture. And just to clarify, when we talk about hip fracture today, we're talking about what we call fragility hip fractures, or fractures that occur when somebody falls from standing height, or perhaps falling from the last step or two down some stairs. So these are low impact fractures, rather than what we would term as traumatic fractures, such as if you were in a car accident or if you fell off a roof or a ladder. So focusing on these low impact fractures. And they are very common. In Canada, we see about 30,000 hip fractures annually. And every year in Canadian hospitals, more beds are used to treat patients who suffer from a hip fracture than from stroke, diabetes, or heart disease. And if we think about some of the most vulnerable patients or people in our society, so people who live in long-term care, they have a lot of frailty, a lot of medical issues. Hip fracture is actually one of the commonest reasons for admission to hospital from long-term care. And we should try to avoid them if at all possible in this vulnerable population. Now, I want to talk a little bit about the average person who suffers from a hip fracture, and they may be, on average, a little bit older than Sue. This is what we call the osteoporosis journey, and the types of fractures that occur depending on what age you are, or the most common types of fractures. So in osteoporosis, you have degradation of bone over time, particularly in women after the menopause, and that leads to increased risk of breaking the bone. So we often see kind of in your 50s or 60s, this is when the fractures may start to occur. And the first sentinel fractures we often see as a wrist fracture. So maybe somebody who has fallen, they're able to put their hands out in what we call a fouche injury, or fall on an outstretched hand, and that leads to that wrist fracture. And that first fracture is the one that may lead to some inkling that there is something wrong with the bones, and that's a really great opportunity to have a bone density test and do a fracture risk assessment, and potentially get treated for underlying osteoporosis to try and prevent other fractures from occurring over time. As we get older, you have other types of fractures that come into play, humeral fractures, pelvic fractures, fractures of the spine. But really, it's in this oldest category that we start to see a higher rate of hip fracture. And the reason for that is because the type of bone that you have in your hip is called cortical bone, and it's thicker than some of the other bone that's found, for example, in your vertebrae. So the bone has to degrade more over time. And also, your hip is one of the largest bones in your body. So for you to be able to fall and actually break that bone over time has gotten weaker. And here, we're looking at time and what we call morbidity, or the amount of, poor effects or after effects that's happened from the fracture. And a hip fracture tends to have the most amount of morbidity or complications associated with it, because just about everybody who has a hip fracture is going to end up needing surgery, hospital admission, as Sue talked about, needing to learn how to walk again and to try and avoid potential post-operative complications. So on average, people who suffer from hip fractures are older. The average age is 83. Frailty is much more common. So frailty is a condition where the body is weaker and may not necessarily be able to respond or adapt to things that are thrown at it, such as fractures, such as surgery. Nearly 20% of patients with hip fracture are from residential care, either a retirement home or a long-term care. 40% will have underlying memory issues, whether that's formally diagnosed dementia or cognitive impairment or memory issues that have not yet been formally diagnosed. And importantly, when we come back to talking about how to prevent further fractures, 95% of hip fractures are a result of falling. So really, we as much as we want to think about bone and how we can strengthen bone, we also need to think about how to reduce falls risk. So I want to introduce you to the hip fracture care team, or the orthogeriatric care team. So this is ours at Victoria Hospital at London Health Sciences up here. And when people come in with a hip fracture, we think about, well, it's the bone needs fixing, but actually it's a very complex condition, which has a lot of people across multiple different departments, and often across different sites and different institutions that are involved in somebody's care. So when a patient develops a hip fracture and they come in, you come to the emergency department, you'll meet your emergency physicians and all of the technicians and nursing, etc., who work down there. And after they do their initial assessment, they will let the orthopedic team know. And as well as seeing the orthopedic team, you are likely to see anesthesia and/or internal medicine in the preoperative phase. And these are going to be the physicians who will look at your underlying medical health issues to give you clearance to go for surgery. In internal medicine and sometimes geriatric medicine, one of the big things we're also looking for is what led to the fall, because in a way that hip fracture is a side effect of the fall. It may have been an accident, like if you tripped over a pair of shoes, or for example, and you ended up falling. But sometimes we see patients who are actually unwell. So they may have been having a pneumonia, and that pneumonia has made them unwell and fall. Or sometimes we see patients who are having a stroke or a heart attack. And so it's the internal medicine team who are screening our patients to make sure that there isn't something else that's going on that also needs to be addressed. During the operative phase, clearly you're going to need to meet your orthopedic surgeon who has the expertise to be able to fix the fracture. And in the post-operative phase, you're going to be meeting a whole load of people. So you have your internists, your geriatricians, your hospitalists. These are people who will be looking after a lot of the medical issues that some patients may or may not have, trying to keep everything in balance if you have pre-existing medical issues, and also being aware of what the possible post-operative complications can be and trying to prevent those from happening. We have the physiotherapists and the occupational therapists who work so hard with our patients, as Sue mentioned, to try and regain mobility. We have our dietitians to help support nutrition. And then even from the very beginning of admission, we want to start thinking about discharge planning or our plans for going home. And that's where our social worker and home care colleagues may come in. And then we go into the rehabilitative phase, which could happen in the acute care hospital, in a rehabilitation hospital, or even at home or in the community setting as well. And here you'll have your rehab specialists, your primary care physicians or practitioners, and your allied health. And throughout the whole thing, we have lots of specialized nursing, our pharmacists and our administrative leaders as well. So not all hip fractures are the same, and I just wanted to show you some anatomy of the hip to try and orientate you, because depending on where you break your hip, the type of surgery may be a little bit different. So here we have your pelvis. This ball area here, this is your femoral head. And this area is called your femoral neck, or the other word for neck is cervix. So the first type of fracture that we have is called a transcervical fracture. So this was right through the neck of the femur. Moving down, you have your greater trochanter over here. So that's the bit of your hip that sticks out when you push on the side of your hip. And then you have your lesser trochanter. And if you have a break that goes right in between your greater and lesser trochanter, this is called an intertrochanteric fracture. And then if you have a fracture that occurs below the lesser trochanter here into the shaft of the femur, this is called a subtrochanteric fracture. And depending on where this fracture occurs, the type of surgery may be different. So these are some 4 common types of surgeries that you may see. So this first one is for a femoral neck fracture. So you can just about make out here that the fractures occurred right here through the neck. And these are called cannulated screws. And they're basically screws that the surgeon puts in right across the fracture to secure the fracture site and allow that region to heal. You're really trying to stop any movement across that fracture line. Similarly, again, this is for a patient who's had a femoral neck fracture. You can see the fracture occurring right over here. This is called a dynamic hip screw. And here a plate is put across across the femoral bone, and then you have this dynamic screw that goes and fixes the fracture across the fracture line. If your fracture extends beyond the lesser trochanter, so into the femoral area, those screws are not going to be enough. And what they actually need to do is put an intramedullary nail, or also called an IM nail, that goes straight down the shaft of the femur. And then you have some screws that go up into the femoral head as well for fixation. So here on the left-hand side, this is a short IM nail. You can see it ends just here. Whereas on this side here, this is a long IM nail, and that will go all the way through to, extends almost all the way down to the knee. And then the other type of more common surgery is what we call an arthroplasty. And this is often done when the fracture occurs very high up near the top of the head of the femur, the femoral head, because if the fracture occurs close to the femoral head, it can affect the blood supply of the head. So for that reason, they have to take the head out and replace it with a metallic one. So this operation here is called a hemiarthroplasty. So only the head is replaced, whereas on this side, this is a full arthroplasty because they replace the head and they also replace the socket in which the head goes as well. So it's a ball and socket right there. So those are the 4 common types. And as you can see, they look very different. So it's important to know which type of surgery that you've had, because the precautions after surgery may be different, and they may have slightly different types of complications as well. So what can you expect before surgery that once you've been admitted to hospital? Well, after you've been seen by the emergency team, we've talked about a medical assessment, and this may be done by the anesthetist and the internist. You will be getting pain relief, and we really are moving towards what we call multimodal pain relief. So different ways of helping to get the pain under control. This could be pills like Tylenol or ibuprofen, Advil. This could be injections with stronger painkillers like hydromorphone or opiate-based medications. And in some centers as well, we do what we call femoral nerve blocks or hip blocks, where local anesthetic is injected into the groin where the nerve is that supplies the hip. And by bathing those nerves in local anesthetic, it is really effective in reducing the pain that's caused by the fracture. And that also reduces the amount of the stronger opiate painkillers that we may need to give people. And it can be a very effective way of getting pain relief. You'll undergo medical testing like chest x-rays, blood tests, heart tracings like ECGs to make sure that you are fit for surgery. A urinary catheter is inserted, so that is going to be a tube that goes directly into the bladder and drains the urine so that you don't have to get up and use the bathroom. It can be very painful trying to move with a broken hip. And it also helps the medical professionals to see how much urine that you're making as well, making sure that your kidneys are working well. And finally, usually the midnight before the surgery, patients are made NPO or no per oral, meaning nothing to eat or drink after that time to facilitate the anesthesia and undergoing surgery as well. And we know that, adequate nutrition is important to be able to recover from surgery. So we do try to shorten that NPO time as much as possible. And in general, the international standard for when you present to hospital a hip fracture to when you undergo surgery is within 48 hours. We know that people who are operated within that 48-hour window do much better and have better outcomes than people who have to wait for longer periods of time. And in Canada, we're a very big country, so I just wanted to give a clarification that 48 hours is really from the time that you present to the first hospital. If you're in a big center like mine, in an academic institution, you come to the emergency department, you will be operated in that same building. Whereas if you live in a more rural community or in a community hospital, they may not have the facilities to operate at that center, and you need to be transferred to a larger center. So that 48-hour clock really does start ticking when you arrive at the very first hospital, not the hospital at which you are being operated on. Things that you can do to help yourself as you wait for surgery. One of the really important things is just to maintain your breathing. get as much air into your lungs as possible to try and prevent complications like pneumonia afterwards. So at our hospital, we suggest that you do lots of deep breathing. So every hour, take 5 deep, slow breaths through your nose and out through your mouth. So, and then do a strong cough. And if you can do that 5 times every hour, it just keeps the air flowing and any secretions out of your chest. And also doing regular ankle exercises, moving your feet around in a clockwise and a counterclockwise way, and pointing up and down as well will keep the blood moving. Now, I wanted to spend a little bit of time talking about delirium, because delirium is probably one of the most common complications that can occur from hip fracture surgery. And this can occur either before the surgery or after the surgery. So it can present at any time. And you may have heard of this condition, delirium, where somebody becomes delirious. And it kind of means when somebody is suddenly becoming more confused. So there's a change in their mental status, causing confusion and changes in behavior. And the key features of delirium is that it's sudden onset, so it can occur within hours to days. There's inattention, so somebody may have difficulty holding eye contact. They may not be able to follow the pattern of a conversation. There may be disorganized thinking, so you may be talking about one thing and suddenly their thought processes may be somewhere else and talking about something completely different, or they may be disorientated. And we often see altered mental status, meaning there's changes to the level of alertness. So people may be hypoactive, meaning that they're more drowsy, maybe difficult to wake, hard to get them to get up and talk and eat. Or it could be the opposite. It could be hyperactive, where people are overactive. So they may not know where their surroundings are. They may be trying to pull their lines out, pull the catheter out, trying to climb out of bed. Obviously, all these things in the context of a broken hip are not necessarily ideal. And we want to be aware that these things are potential changes from normal, so that we can try and prevent them from happening, or if we do see them, we're able to address them quickly. And I would say that if you look at the research studies, up to 50%, 50% of people with a hip fracture may develop delirium at some point within their hip fracture journey. So what are the potential risk factors for delirium? Well, there's the person-centered factors, and then there's also things that can precipitate the delirium. And if we know what the risk factors are and the things that can cause it, we can be aware of them and try to prevent them from happening. So some things you can't change. So the older that you are, the higher your risk of delirium. If there is a history of dementia or cognitive impairment, any memory problems, that will increase the risk. And one of the biggest possible factors is if you've ever had an episode of delirium before, and that doesn't need to be in the context of having had a hip fracture. It could be if you've been sick before, if, for example, if you had a urinary infection or pneumonia, if you've been admitted to hospital in past and you've had episodes of confusion, that's probably one of the highest predictive factors that this may occur again. If you have multiple underlying medical issues or any history of excessive alcohol use as well. So that is something that is important to let your healthcare providers know about, so that we can take the necessary measures to reduce the risk of any complications there. And as for the things that could potentially cause the delirium, well, the fall and the fracture and the trauma itself can lead to delirium. Pain, whether it's uncontrolled pain, where we're giving too much painkiller, particularly some of our stronger painkillers like opioids, can lead to delirium. And I'm just going to mention as well that we know that patients who have underlying dementia or cognitive issues, they often don't get as much painkillers as people who do not have cognitive issues, because they may not be able to voice the fact that they have pain. And if their pain is not well managed, that can make them more confused. So as family members, care providers, or friends, it's important to be able to try to pick up on some of the cues that your loved one is telling you, because you know them better than some of the medical professionals, and be able to flag if you think that somebody is in uncontrolled pain. We have to be careful with the medications and anesthesia we give. Sometimes even the change of environment itself can cause people to become more confused. I know when I go to the emergency room, sometimes at the hospital that I work at, it can be so disorientating. There's lights and sounds everywhere. Even I feel a little bit delirious. sensory impairments. If you can't see and you can't hear properly, that can make things worse. If there's coexisting medical issues like infection and poor sleep, being able to maintain good sleep is very important. So on the left here, this is the infographic from the Regional Geriatric Program of Toronto that highlights 6 proven strategies to try and prevent delirium in old adults. So stimulating the mind, moving with a therapist after surgery if you can. As I said, sleeping well is important, seeing and hearing everything that's happening, staying hydrated, avoiding dehydration, and eating well. Things that we can do as medical professionals is after the surgery, try to get all the lines out as quickly as possible. So we want that catheter out the first day, try to get the IV lines out, avoiding constipation. So constipation may seem like a common thing, but it is a really big factor in hospitalized people developing confusion. Making sure we have adequate pain relief, and making sure that we are not giving inappropriate medications. So there are classes of medications that we call deliriogenic medications, medications that are known to cause confusion. And some of these can be very common over-the-counter medications like Gravol, which is used for sleep or nausea, Benadryl that can be used for allergies, or sometimes sleeping medications like Ativan. All of these are known to cause confusion in older adults. And when we do start medications, we use the mantra, start low, go slow. That's a geriatric mantra. So you want to start at the lowest dose and increase the medication doses rather than starting at a high dose and running into complications. And what can you do with family members and friends to try and mitigate the risk of delirium? Well, we know what can potentially cause it or precipitate it, so we want to try and avoid these things as possible. So please, please bring in any glasses or hearing aids. Anything we can do to optimize the senses is beneficial. Bring in any familiar objects from home. Lots of people might like to bring in pictures, picture books, and albums. If there's a comforting blanket from home, or if there's any stuffies or anything that people find particularly comforting, please bring those in. They're very helpful. Anything to keep the mind stimulated. So activities, if there's any hobbies that people enjoy at home, knitting, crosswords, bring them all in. In hospitals, sometimes it can get quite lonely, as Sue said, and there are often long periods of time where there may be inactivity, and being able to do things to keep active, if it's not physically active, keep your mind active is very helpful. And that goes with music, tablets, radios, etc. And just be there to be able to encourage as much as possible as they go through this journey. So that's the preoperative. We've made it through surgery. Woohoo! So we're on to the other side now. What can we do to try to optimize our recovery? So there are 2 things that I ask all of my patients to do, and I think Sue has talked about these very eloquently, which is move and eat. So the first time I met Sue, similar to the story that she gave, she said, you know, I had surgery. It was late in the afternoon. I was quite tired. The next day, 9 o'clock sharp, we had a physiotherapist at bedside saying, come on, let's get out of bed. And even though, you know, she was tired and in pain, got up and persevered. And that's probably the best thing that she can do. And I'm going to give you some evidence to show you how getting out of bed early helps improve your outcomes. So you can expect to be getting out of bed and starting to move either the day of or the day after surgery. And for hip fracture surgery, it's pretty much universally accepted now that patients should be weight bearing as tolerated. And that means that when you're getting up to walk, you can put as much weight through the operator's leg as you are able to tolerate. There doesn't need to be any weight bearing restrictions there. You want to get out of bed because immobility and bed rest is one of the worst things after surgery. You can lose 2 to 5% of muscle mass every day that you're lying in bed and immobile. And in older adults, you can lose up to 10% of your muscle mass in 7 days. And as you lose muscle mass, you're also going to become weaker. And that's something that we call deconditioning. And if you're already trying to improve your function after surgery, and it's kind of an uphill battle, if you lose 10% of your muscle mass, it's even harder to get back to where you were before. So we want to avoid that muscle loss if at all possible. And I want to also emphasize that participating in any activities during the day, not just the 10-15 minutes that you're with your physiotherapist or occupational therapist, everything you do is part of your rehabilitation. So getting up, getting dressed, sitting on the commode, transferring to a commode, walking to the bathroom, walking with your nursing staff. All of this is part of rehabilitation because these are all the things that you need to be able to do to be able to get home. So this is a study from the UK. It's a large database study that just highlights how important it is to get out of bed. So they looked at over 120,000 people who had hip fracture surgery, and they divided them into people who either mobilized on the day of or the day after surgery, or what they called delayed mobilization, which is 2 or more days after the surgery. And then they looked at how likely are these patients to survive 30 days after the surgery. And what you can see here is those people who mobilized early had better outcomes with regards to mortality. So 96% of people who got up early the day of or the day after surgery survived to 30 days. Whereas if you were a delayed mobilization, that number was lower, 89%. And then when they split the patient groups out to see, does having dementia have an effect? We find the same thing. Whether you have dementia or you don't have dementia, getting up early, day of or day after surgery, improves your ability to survive the surgery up to 30 days. So 97 and 93% as opposed to 91 and 87%. And we see this not just with survival, but also how likely it is you're going to be home in 30 days. So again, another big database study from the UK looking at over 135,000 people, and they divided the patients into either early mobilization, which is getting up and moving within 36 hours of surgery, or delayed mobilization. So these are people who didn't get up out of bed until 36 hours or after. And people who mobilized within 36 hours were twice as likely to be discharged home within 30 days. You can see that these lines diverge quite early on. And by 30 days, if you were in the early mobilization group, nearly 80% were home. Whereas if you were in the delayed mobilization group, a good proportion of them, looks like almost 50% of them, are still in hospital. So getting up and moving that first day, like the physiotherapist did with Sue, is so critical to recovery. So what would you expect to do in that first couple of days? This is what we recommend at our center. I would say that this is probably for somebody who is independently mobile before. If the person's mobility was lower, for example, had difficulty standing from a chair, had difficulty walking, even before surgery, then their targets may be a little bit different. But really, day one, you're expected to begin your bed exercise program, working with their therapists. Sit at the edge of the bed, stand with an aid if you're able to, maybe take a couple of side steps up and down the bed. And if we can transfer you or get you sitting in a chair, that would be wonderful. By the second day, our catheters come out first day because we were trying to get all of the lines out. So by second day, we're really trying to be able to get onto the commode every time we need to use the bathroom. So pivoting onto the commode. Now we're working on getting up to the chair twice a day, starting to take those little steps with the gait aid. And working with our occupational therapies on our activities of daily living program. So those are things like brushing your hair, brushing your teeth, grooming, putting on your clothes, feeding, all of those things that you need to do on a day-to-day basis. By the third day, we're aiming to get up to the chair for meals. So breakfast, lunch, and dinner. Get out of bed. We don't want that immobility. Sitting up in the chair is good for your core. It's good for your lungs. It gets more air into your lungs. You're able to expand your lungs much more than if you're lying hunched over in bed. Want to be able to start pivoting to the commode or walking to the bathroom and continuing to work with our allied health. And from day 4 or 5 onwards, it's continuing progression with mobility, continuing with progression to independence with their activities of daily living. So moving was the first thing. Second thing is nutrition. Nutrition. This is very, very important. And it's often something that is overlooked in the overall scheme of the recovery process. So why do we need to get adequate nutrition? It's required for bone healing and tissue repair. It reduces post-operative complications like infection or development of pressure or bed sores. You need adequate nutrition to support your muscle strength and mobility. And like we said at the beginning, we don't want to go through this again. So we need adequate nutrition to strengthen our bones, and our muscles to prevent further fracture and to improve our long-term outcomes. Malnutrition is very common in the patient population who have hip fractures, and this may not necessarily be malnutrition that develops because of the fracture. A good proportion of our patients, particularly our frailer patients, are already malnourished when they come into hospital to begin with. And it's our jobs as healthcare providers to recognize that malnutrition, to screen for malnutrition, and to be able to get the right help in place, such as involving our dietitian and making sure that we're counting or quantifying the food that we're providing and the amount of food that our patients are taking in as well. So these are some examples of some of the major nutrients that we want. Sue had already mentioned about protein and calcium. So if you go onto the Osteoporosis Canada website, and I've provided a reference at the bottom here, they have really great resources on nutrition for bone health. For the average person, you're looking at 0.8 grams per kilo per day of protein. But after you've broken your hip, you actually need higher amounts of protein to help you through that recovery process. And we're aiming for 1.2 grams per kilo per day. Calcium, we're aiming for 1,200 milligrams a day through the diet, if at all possible. And just for reference, a glass of milk or milk alternative like soy milk or almond milk that is calcium fortified is about 300 milligrams. A cup of yogurt would also be about 300 milligrams as well. And vitamin D is an essential building block to be able to help strengthen your bones. So for all of my patients, I will start at least 1,000 international units of vitamin D, and I'll usually titrate that depending on what their blood serum vitamin D levels are. Fiber is important to avoid constipation because we want to avoid delirium, and also making sure we have adequate fluid intake as well to avoid dehydration. So things that we consider outside of just how much is people, how much food are we offering and what are we offering? As I said, we try to minimize the time that somebody is milk or oral. We want to look for pre-existing malnutrition. We need to think about whether somebody has other medical conditions or dietary restrictions that may affect the food that they can have. So for example, cardiac patients, kidney patients, patients with diabetes, they may have dietary modifications that need to be made to make sure that the food that we're giving them is also good for their other medical conditions. And there may be physical and cognitive impairments as well. If we give you food, is the patient able to open the containers to access the food? Do they have deformities of their hands and their joints that need adaptations to the utensils that we're giving? Is there significant cognitive impairment? Is person able to feed themselves, or do they need support with feeding? And these are all things that we need to think about to be able to optimize nutrition in this patient population. And Sue alluded to this a little bit, but mood is also something that we need to be aware of as well. And this is a major event that's happened. It's not surprising. Sometimes people can get down after this, particularly people who may have pre-existing depression or anxiety even prior to the hip fracture. And sometimes that can manifest with not wanting to eat and having little interest in food. So that's something that if you're concerned about, please flag it to the healthcare team because it needs to be looked into and addressed. How can families help support? Meals are a very social thing. There's good evidence to show that when you share a meal with somebody and you're enjoying yourself, you're more likely to eat more than if you're sitting alone in the corner by yourself trying to eat a tray of hospital food. If you want to bring food from home cooked food, foods that are more similar to what the patient may be used to eating, by all means, is something that we often will encourage our families and friends to do. When you're around, please encourage food and fluid. Little and often throughout the day is often a good idea. When I come and see my patients together with my residents and students, we will always encourage or provide food or fluids when we see patients. And just knowing that the food is accessible. So sometimes I'll go and I'll see this tray that's laden with like 5 different types of drinks and snacks, but the tray is all the way on the other side of the wall and is out of the reach of the patient who isn't able to get out of bed. So unless it's actually accessible to them, they won't be able to take it in. So making sure it's close to them and just consistently offering. And if you do have concerns, please inform the staff so that we can keep an eye on things and help support nutrition. So what are some of the signs and symptoms that we might be concerned about post-operatively to look out for? So when I think about this, I often think about, well, what are things that could go wrong from the surgical perspective? And then there's everything else, which tends to be the more medical realm that I'm involved in. So a lot of the surgical area we're looking at is the wound. So if there's any redness or swelling or a lot of like pain out of proportion than what we would expect after the surgical time, then that is something that needs to be addressed by the medical or surgical team. And the orthopedic nurses are very, very knowledgeable about this. And they will be changing the dressings on a regular basis, looking for things like post-operative infection. If there's any opening of the wound, so you can see here that this incision line, all of the stitches are in place, but if any of these start to open and you actually have a gaping of the wound, then that's something that needs to be looked at by the medical team. Or if there's any discharge that's coming from the wound, whether that's like a clear color, or if it's yellow or green, or if there's blood-tinged fluid, that's something that also needs to be looked at. Often we'll take a sample or a swab and send it to the lab to make sure that there's no infection, or sometimes we look to see if there's a collection that is developing underneath the incision site as well. With regards to kind of other post-operative complications, this is not an exhaustive list, but this is some of the more common ones that we see. So if you have significant leg swelling and pain, it is quite common to have some swelling in the operated leg, but if it's continuing to get big and is very painful, particularly lower down, it makes us worry about things like blood clots. So we may send patients down for an ultrasound scan to exclude that. If you develop shortness of breath, coughing, or pain when you're breathing in and out, that makes us worry about things like blood clot in the lungs or developing pneumonia or heart failure. So further investigations either with x-rays or CT scans might be necessary. Delirium we've talked about already. As I said, up to 50% of people can develop delirium at some point, and that's something that we need to watch for very carefully. A lot of patients may come in with pre-existing health conditions, so heart disease, diabetes, kidney disease, or neurological conditions like Parkinson's or stroke. And when you go through a big surgery, there's been a lot of changes, medication changes. Sometimes those conditions can get out of kilter. So one of the jobs of the physicians or the healthcare team is to make sure that we try and keep all of those other conditions under control and we don't end up with a decompensation or worsening of those pre-existing conditions. If you spend too much time in bed or are not turning adequately, it's possible to develop bed sores. And people who are more likely to develop bed sores are those who have, a lot of prominence in their pressure areas. So if they're slimmer, and if they're malnourished as well, or if there's other factors like if there's a lot of moisture or liquid, such as if people who have continence issues. So common areas for bed sores and skin breakdown is in the sacral area, just at the bottom of the back in the coccyx area, and also on your heels as well, if you're lying in bed and your heels are on the bed. So these are areas to try and offload. Don't put too much pressure on them for too long a period of time. And also mood, again, is something that needs to be kept an eye on. So that's your kind of pre-operative and post-operative period, and hopefully we'll be able to avoid post-operative complications and to be able to work with our physiotherapists. As Sue says, just do what the physiotherapist and occupational therapists tell you to work towards independence and mobility again. But what can we do to try and prevent another fracture from occurring again? So I always think of this like a peanut butter and jelly sandwich, and the two sides of this coin, or two sides of the sandwich really, are falls and fractures. So we need to have targeted strategies to try and reduce your risk of further falling and reduce your risk of further fractures as well. So everybody who's had a hip fracture needs to have a fracture assessment or an osteoporosis assessment. And generally, this is fairly easy. If this is going to be a low impact fragility hip fracture, these are high risk fractures. And a good rule of thumb is that everybody who's had a fragility hip fracture needs to be assessed for osteoporosis and secondary causes of osteoporosis, and should be started on treatment for osteoporosis. And that treatment needs to start fairly quickly. 1 in 3 patients who've had a hip fracture are going to refracture within 1 year. And unfortunately, across the world, this is something that we are not particularly good at addressing and making sure that happens. Only about fewer than 20% of patients who've had a fracture will undergo adequate diagnosis and treatment for osteoporosis. And this is something that we have been pushing very hard, developing algorithms within hospitals to try and get patients started on treatment before they leave the hospital setting. There are a large variety of medications that are available here in Canada. Each hospital is going to have a different set of medications that are available on their hospital formulary, and each province will have different reimbursement regimes as well. So what will be available and what is best for each patient is going to be tailored to that patient, taking account of their other medical issues, access, and funding, etc. But I think the biggest thing to take home is that if you've had a fragility hip fracture, you need to be started on some treatment. Some treatment is better than no treatment, and making sure that somebody has done the assessment and has addressed the bone health. With regards to falls, it's very important to get people on treatment, absolutely. If I could stop people from falling, I could probably reduce the number of fractures that occur even more than just giving out medications. And the way that we think about what causes somebody to fall is 2 things. We think about our intrinsic factors and extrinsic factors. And intrinsic is anything within your own body that may be contributing. So that may be if you have a neurological condition like previous stroke or Parkinson's disease or balance disorders or problem with your ears that's affected your balance, or if you have heart issues, arthritis, muscular weakness. And again, we come back to sensory. If you have poor vision, you can't see where you're going, and you trip over everything. These are things that as physicians, we need to try and identify and address and reverse if at all possible. And then you have your extrinsic factors, which is everything outside of the body. So these might be medications that we're putting in. If you have polypharmacy or a large number of medications, they may start to interact and cause problems with blood pressure or cause problems with dizziness or sleepiness. And those are things that we need to address. And you have to look at your environment as well. Is there clutter? Is there trip hazards? Are people wearing inappropriate footwear? If I was wearing 3-inch heels out in the snow today, 100% I'd be on the floor because of my inappropriate footwear. And the way that we address reduction in falls is usually through an interdisciplinary assessment. So you need your physician to look into these intrinsic factors, but then you need your physiotherapists, your occupational therapists, and other members of the allied health team to be able to look to see what are some of those other extrinsic factors that may be contributing to falls. And we may need our nursing and our dietitian to help with some of support some of these medical things like poor nutrition, muscular weakness, etc., to be able to look at a person holistically, stand back and think, what are all of the possible things that could be contributing, and address them one by one. So in summary, this is a very quick tour of hip fractures, but I hope that I've demonstrated to you that hip fractures are complicated presentations to hospital and often occur in older adults with higher levels of frailty, and they may have complex multiple coexisting medical problems. And the patient journey itself is very complex, involving many members of the medical, nursing, and allied health teams that occur across multiple settings. And by developing cohesive and proactive systems of care, we can really optimize recovery. And as a patient or a patient care partner, knowing what to look out for and how to support a loved one through their journey and advocate for them makes all the difference in trying to get the most out of optimizing recovery from hip fracture. So thank you very much. Happy to take any questions.
Thank you, Jenny. That was great. So much information to think about. We'll now turn to the question and answer period, and we'll do our best to get to as many questions as we can in the time permitting. So let's start with this question. Jenny, what's the best way to prevent hip fractures?
So I think the best way to prevent hip fractures is again looking at that kind of dual pronged approach, which is around falls and also about bone health as well. So I talked a little bit about, that osteoporosis journey. If there's evidence that there may be osteoporosis earlier in life, you really do need to get that looked at, get your bone mineral density test, be assessed, do a fracture risk assessment, and get on treatment early so you can prevent those later fractures from occurring. The second thing, and I probably also need to apply this to myself as well, is that we don't want to wait to have the hip fracture or until we get older before we start taking part in exercise. This is something that needs to be done early on in life. We know things that improve balance and improve core and strength. These are the things that are going to help you later on in life. And the earlier you get started with it, the better. Everything I'm doing for myself now, I'm thinking about I'm investing in future me. So functional exercises, resistance exercises, all of those are very helpful. And, I often have people who come to clinic and will say, oh yeah, Dr. Thain, I had 3 falls this year, but they were all kind of accidents and I didn't hurt myself. So I think they're fine. You want to really take those as an indication that we need to be proactive and do something now. You don't want to wait and have an injury before we start being proactive about balance, core and resistance training, diet, and bone health. All of those should be done early.
Great. The next question does relate to that. The person is asking, do falls prevention programs offered to seniors help in preventing hip injury and fractures to some extent?
Yes, I think that they do. The different programs may be different. You have some programs that are more active. You may have some programs tailored towards more like seated exercises, etc. I think taking part in any of those programs are helpful. And the seniors programs are often a really great way to get connected to other services as well, who may be able to have more information. So for example, if you go to one of those exercise programs and you mention that you may be falling, they may be able to give you information about how to access an occupational therapist, for example, to be able to come to your home to look to see if there's any environmental hazards and look at all of those extrinsic risk factors so that you are able to uh, look at home safety proactively. I think, through Osteoporosis Canada as well, you have the Bone Fit programs, which are exercise therapists who have extra training in osteoporosis and bone health as well. So those are the therapists that I tend to recommend to my patients because they will have a holistic understanding of exercise, strengthening, and bone health.
Great. We have time for one last question. This is the question. The person writes, I've had both hips replaced. Can I still get a hip fracture? And if yes, do hip fractures happen more easily after hip replacement?
So the type of fractures that tend to occur if you've had a hip replacement is what we call a periprosthetic fracture. So it may not fracture through the hip in the same way that I showed in the pictures, but for example, if you have a ball and stem, the fracture may occur at the bottom of the stem where the native bone is. That is a common type of periprosthetic fracture, or sometimes you can get fracture that occurs in the bone around the metal replacement as well. Those are definitely within the realm of the orthopedic surgeons, and the types of surgeries that they do for those are a bit different from what would occur if you have a hip fracture through native bone. I'm not sure I would necessarily say that you're more likely to fracture if you have a pre-existing hip replacement, but they can happen, which goes back to the importance of falls prevention.
Okay, that's about all the time we have for questions. So at this point, I would like to thank Sue for sharing her story with us, and to Dr. Thain for such an informative presentation on hip fractures and navigating the healthcare system. So for more information on osteoporosis, please visit our website at osteoporosis.ca. We have several upcoming events. You can learn more about those on our website. And as well, on our website, we have many tools, including our new nutrient calculator. We have podcasts, quizzes, and a repository of past webinars. So thank you all for joining us today, and hope to see you again soon, and wishing you a great day. Thanks for joining us.